Today we welcome Dr. Boockvar. He is a neurosurgeon vice chair over at Lenox Hill in New York City. This is actually our second educational Zoom with him. We've done 5 with Lenox Hill already, so really excited to learn from him today. For those of you out there who have not heard, the Brain Tumor Companions are fundraising this year for Dr. Boockvar's research. And so today we're going to pass off the Zoom room to Dr. Boockvar and allow him the opportunity to share with us a little bit about what's going on over there and how our fundraising efforts can help. So the Zoom room is yours.
Well,
Dr. Boockvar, welcome.
thank you so much. And not only do I love the opportunity to talk to you guys, and I thank you. I just got your T-shirt from one of your colleagues as well, and so thank you for your ongoing support. And it goes both ways. It's a two-way street with education. And I have so many patients who I ask. They say, John, I got introduced to this trial. Could you vet this for me? And actually, educational episodes and opportunities like this is a two-way street. So I try to educate you, but so many of my patients educate me. So thank you for the opportunity. I
Absolutely. No.
actually, I thought it would be fun and different to actually talk about something that I think is really important, not just for meningiomas, not just for gliomas, not just for brain tumors, but actually for sort of humanity with what we're doing. And I'm going to talk only for maybe 10 or 15 minutes, and then I'll open it up. But I thought this would be something that might pique your interest. So um, let me share my screen here. Angel, do you see that screen? Like that you guys see that okay?
Yes.
So I'm just going to introduce a couple of the ideas that I think are relevant to anybody who's struggling with a brain tumor, whether it's a meningioma or any other type of tumor, is something called the blood-brain barrier. And one of the reasons why we're unsuccessful in treatment of brain-related diseases is this entity called the blood-brain barrier. And so I thought it'd be important to obviously introduce our group, but I want to just tell you why this has been sort of a fixation of mine. But as Angel said, and many of you know, we are really excited about what we're doing here at Lenox Hill. And I've only been at Lenox Hill for 10 years. I trained at Penn and was at Cornell for 10 years. And I really have to give credit to Northwell Health for really coming onto the scene about 12 years ago in New York State. They were granted the first MD medical school program, the first MD medical school in 40 years in New York State. And they've really become a very forward-thinking, kind of less bureaucratic healthcare system. So when we talk about novel treatments, Northwell Health has really become a place where investigators like myself like it a little bit better because there's a little bit less red tape. And we still have this startup mentality. And as you can see in some of these pictures, it's an intimate setting with a lot of researchers. Obviously, you can see a picture here in our laboratory setting. So we're moving a lot of what we learn at the bench to the bedside. And there's just a huge amount of people to thank. This is a sunny day picture of Lenox Hill Hospital, which is on Park Avenue on 77th and Park, between Park and Lex. And it's actually a very intimate place that allows a lot of attendings to interact all the time together. A lot of the big monstrosity hospitals, which I think are effective, are almost too big for that sort of intimacy. And the way I describe it, not like I've done this very often, is if it's like the difference between flying out of JFK and flying private. You may not have 50 options, but flying private is a real luxury. Lenox Hill Hospital is a very intimate, nice experience. I like to say it's a pond with this ocean of research behind it. And our programs in research are quite voluminous. And as you can see here, I run 36 human trials of all different types. Obviously, it's really important for our patients to enroll in clinical trials. We're the leading enroller across Northwell Health, which is the state's largest healthcare provider of 24 hospitals and 4,000 physicians. So we take our clinical research program very, very seriously. So when we're raising money for our basic science and clinical research programs, all of that money is going into our patients who are being trialed, if you will. And we encourage everyone to be involved. So our nurse practitioners, our physician assistants, our residents, our fellows, our attendings, and you can see the national average for brain tumors enrollment is only 5% in clinical trials, but at Lenox Hill Hospital, it's over 66%. So we're trying to spread the word, and obviously organizations like yours, and we have meningioma trials as well. And as many of you know, that there are far fewer meningioma clinical trials than there are in glioma and brain cancer trials, and that's a discussion for another day. But the reason for that is many of our patients with meningiomas are either cured with surgery or are just being conservatively followed. The atypical and even malignant meningiomas are increasing in their number of clinical trials that we offer. But I wanted to talk about some cool stuff we're doing with blood-brain barrier disruption, particularly with ultrasound. And you all know that ultrasound is actually pretty rudimentary imaging. And we've all seen ultrasounds maybe of your belly, if you're pregnant, of a fetus, or of your carotids, or something like that. And we are using ultrasound now at the point of care with patients like yourself to open the blood-brain barrier. So this is where the puck is going. And this big picture that you see here with this bubble in the middle of that blood vessel, that's actually a 3D rendering of the blood-brain barrier. So what you're looking at is this cross-section of a blood vessel, and the little green things that are kind of moving, they look like little eggs. Those are drugs that are coming out of the blood and going into the brain tissue. And that big bubble is something called a microbubble. And when we give microbubbles, which are little, we give them intravenously to patients, and you pass an ultrasound, those microbubbles will get bigger and actually will open the blood-brain barrier. So I'm just going to talk about a couple of trials that we have because they may be relevant for you all in the future if we get this right. So here's your blood-brain barrier. I just want you to know what your blood-brain barrier is doing to protect your brain. I mean, evolutionarily, we built up the blood-brain barrier so in case we got bit by a boa constrictor, that venom wouldn't get into our brain. Well, that's a problem if you have a brain tumor. So again, we are giving microbubbles, which you can see starting at the right of the screen is a small microbubble. And then when ultrasound passes past this microbubble, it enlarges the microbubble and actually causes the blood-brain barrier to open. And you can see these green little eggs squeezing out of the blood vessel into the brain. And so that's how we're going to do this. So how do we do this? Well, there are a couple of companies that we're working with, and we're going to be applying this to a host of things. One is called Alpheus. Alpheus is a new trial that we're showing. Some of you may have heard of something called 5-ALA. 5-ALA is a drug that is specifically picked up by brain tumor cells and is not picked up by healthy cells. And we have a trial with atypical meningiomas and malignant meningiomas looking at whether they pick up 5-ALA. And as you can see in the patient up top, he's drinking the drug the morning of surgery. That drug accumulates only in brain tumor cells and not in healthy cells. And then we ultrasound through the skull. And actually, when the ultrasound hits that drug, it actually lights it up and it basically becomes a free radical and actually causes cell death. And then the immune system is involved in breaking down those cells and removing them from the body. So think about that. I could actually give a patient a drink, not open their skull, just ultrasound at the point of care in the office, cause oxygen-free radicals in those cells, and actually have the immune system. So this is a company you may hear about and a trial that we have. Another similar idea, which involves surgery, is a company called SonoCloud. As you can see from this schematic, this is a little different though. I actually have to remove part of the skull, and instead of the skull, I put that little inset, which says A as an apple. That's actually a piece of your skull that's going to have an ultrasound built into it. So it's actually a device that if I stick a needle through your skin, it will activate the ultrasound and actually do the same thing that I told you about with microbubbles. The microbubbles sonicate and get big, and then you can take a chemotherapy at that same time while you're getting ultrasound, and that chemotherapy can get into your brain. So this is going to be another trial that we just got IRB approval for, ultrasound mediated blood-brain barrier disruption. In fact, not only for brain tumors, and this is what is really exciting, is that I don't know if you saw 60 Minutes, maybe 4 to 6 weeks ago, this was on 60 Minutes, that we can use ultrasound to open the blood-brain barrier and give an Alzheimer's drug that doesn't normally penetrate the blood-brain barrier. And actually, we showed, not we, but my colleague in West Virginia showed that, again, ultrasound-mediated blood-brain barrier disruption can improve the delivery of an Alzheimer's drug for patients with Alzheimer's. So they actually trialed this by giving half the brain ultrasound and not ultrasounding the other half of the brain. And the brain that had ultrasound showed lower levels of basically deposits that are common in Alzheimer's. So imagine the amount of people that we can help with something that's non-invasive, available to all, doesn't hurt, and as simple as ultrasounding. And I know your question is, heck, John, why didn't we think of this sooner? And the answer is, I have no idea. But we're here now, and it's an exciting time. Here's a paper that was just published from the 60 Minutes paper. Again, you can see the date was January 4th, 2024. This is new. So this was on 60 Minutes and this is a neurosurgeon, Ali Razai, who's a good friend of mine. He's in West Virginia. So neurosurgeons, I never thought a neurosurgeon would be actively involved in the treatment of Alzheimer's disease, right? I'm a surgeon. But now you can see that if we're doing ultrasound, and we're able to treat the holy grail of human disease, Alzheimer's disease. If there's only one thing harder to treat than cancer, it's Alzheimer's. And that's because it's a diffuse disease. But here we had the opportunity to ultrasound an entire hemisphere and reduce the amount of amyloid deposits, which is a surrogate of Alzheimer's disease. So how do we do it at Lenox Hill Hospital? So it gets even cooler. You can see these implants that I'm showing on your screen. These are called clear fit because they're clear. They're sonolucent, meaning that you can ultrasound through them. And the company's called Longevity. So instead, if I did your meningioma and I wanted to use one of these, I would take out your meningioma and by removing your skull, and then normally I'd put your skull back on and maybe some other implant. Well, this implant now, which is called the ClearFit Sonolucent Customized Cranial Implant, is ultrasound permeable. So now in the office underneath this window, I can actually give microbubbles like I showed you, and ultrasound, and actually get right through this window. I'm going to skip to a picture. So here, this is an actual person who's agreed to allow us to use his face. And actually, this is my OB/GYN because they're so good with the ultrasound. We don't really know how to ultrasound. So he's ultrasounding through one of our cranial implants to look at the brain. So you can imagine that it often takes other disciplines who are well-versed in technologies that we're not familiar with. So here you can see a collision of really two different disciplines. Here, obstetricians use ultrasound every day. Neurosurgeons rarely do, and yet we're coming together to improve treatment. And here are some of our implants. So all of these are types of implants. You can see these clear implants that we use, and they all are different sizes. We can put them in for just about any type of size. I envision one day where Alzheimer's patients may get an implant that is ultrasound permeable, with the idea that we do this. This is a patient that allowed me to, so this is a patient with a brain tumor. I put a cranial implant like you just saw, clear fit. And we're at the bedside now in my office. We'll be able to open her blood-brain barrier with ultrasound through this clear fit implant, meaning that I can give her a pill, I can give her intravenous chemotherapy. I can give her a pill for Parkinson's. I can give her a pill for Alzheimer's. And so we're really excited about this. We just started doing this. This is right off the press. And I think it's going to be something that is going to offer a lot of our patients durable relief. So you can see the market that this is good for, not only brain tumors, but Alzheimer's disease, Parkinson's disease. This can improve the treatment with things like chemotherapy with Temodar or carboplatin. Cell-based therapies will improve the treatment in the brain, including things called CAR T cells or cell-based therapies. It will improve the delivery of oncolytic viruses, which is everything we've been doing in neurosurgery to improve the treatment of meningiomas and brain tumors should get better. That's my old stomping ground. So I just wanted to introduce that concept. I thought it was it's hot off the press. So I thought you
Yes.
deserve to be the first to hear about it. And I think ultrasound, you'll be pleased to know we're targeting something that's never been targeted before, which is the most important thing to target, which is the blood-brain barrier. So I thought I'd just introduce these concepts to you in a short little overview.
I love that. I love that so much. Thank you. And I have seen a lot of presentations in the last few years and talked to a lot of neurosurgeons, and that is fresh off the press. I think by raise of hands, we can all say none of us have heard of this, seen of this, right? No, it's news to us. So really very cool, and love what's so great about you guys over there, aside from that intimacy that you talked about, is you're collaborating kind of between the departments. Like you said, I'm not just going in and doing surgeries all day, nurse, like we can help everybody and kind of heal a lot of different things, which is really so wonderful. Did that presentation bring up any questions for anybody that they might want to ask? Rona?
Hey, hi there. Thanks for being here. I'm wondering, what is the advantage of that clear window? Is it for ultrasound, or is it for like you to visually see something happening in the brain?
It's a great question, and the answer is both. So it technically is sonolucent, meaning that it's ultrasound. So your skull and my skull is actually not penetrable by low frequency ultrasound. Either you need a high frequency ultrasound device, which many hospitals can't afford. It's well over $1 million. Or what this implant does, Rhoda, is it provides the ability to use commercial ultrasound that now is penetrable through this implant. So when we say sonolucent, it means it's ultrasound permeable. And I think it was serendipity that the company basically stumbled upon it. I don't think the intent was ever to do it. They were working with a PMMA construct, and they literally by serendipity found out ultrasound waves penetrated it. And so what's really cool is after surgery, if I do a meningioma, I can actually put an ultrasound on this implant and see if there's a post-op blood clot. A lot of meningiomas are very big. So when I remove them, the risk is that there's a post-operative hematoma. If I take out a lemon or a mango or something big, blood can fill those cavities. I actually return somewhere about 1 in 100 patients for a postoperative hematoma to the operating room. So knowing that the patient is not accumulating blood in that operative cavity without having to wheel that patient to a CAT scanner is saving us huge amounts of time and money.
Wow. Yeah. Any other questions? By raise of hands, anybody? What is the like recovery time for something like that? Just out of care, or is there an increased risk of like infection or
That's a good
delicacy?
question. So anytime you put an implant in, you would think that it's not your tissue, right? So it's not autologous. And so it's a foreign body. But as you know, even when we put your native skull back on your own skull, I have to hold it in place with titanium mini plates. That's how it's structured. You've seen that, right? I'll show you this.
Love this. Love it so much.
So you've seen these, right?
Yeah.
These are titanium little mini plates that hold skulls back together. This is a implant from that company. But even if I use your native skull, these titanium MRI compatible mini plates are what hold us together. So the answer is anytime you use a foreign body, there's a theoretical risk that it has a slightly higher infection rate. knock on wood, these are made of PMMA, which is polymethyl methacrylate. They have a very, very low rate of infection. And so for our patients, the majority of them, the risk of infection is completely outweighed by the benefit of being able to deliver chemotherapies or other drugs to them.
Right. Rona, you have a part 2 question?
Yeah, I mean, aesthetically, like thinking about the broad applicability, I assume hair will never regrow on these plates, right?
No, they absolutely do. The scalp
Oh, they
is,
do.
oh, you remember your scalp is covering it.
Yeah. Okay.
So
Okay.
I can peel back your scalp and your hair follicle is completely intact. You would never see any of these plates. In
Okay.
fact, in that picture of that woman, she had gorgeous red hair. I didn't have to shave anything.
Yeah. Okay.
These are
Okay.
under your scalp, your follicles, unless you get radiated, which can kill a hair
Right.
follicle. But this is not something you'll be able to see. Your scalp is covering it.
Got it. Makes so much more sense. Thanks.
Yeah. Wow.
That's amazing.
Seriously, really cool stuff. Really glad to be supporting all of that and to be a part of it. So thank you and appreciate you sharing with us kind of first, if you will. Can't wait to share it with everybody now. Well, then we'll move on to the Q&A section of the session. Unless Dr. Boockvar, did you have anything else you wanted to share or present, or shall we move along with some
We can move
introductions?
along.
Okay, great. So in case you're wondering why everyone has a number next to their name, it's just to tell you how many times they have joined a support group that I have hosted. They're usually 2 hours long, and we do what we're doing right now, although not quite as interesting as your presentation, maybe. But anyhow, we always invite new people to come and join our community, and never be shy. We are real, and we do love to kind of learn and grow together. So that's what the number is next to everyone's name. But we'll start off today with Lisa. If you can just, I'll call names, and if you can just, Lisa, introduce yourself, give us an update on your medical condition, and ask Dr. Boockvar your question.
Okay. All right. Well, thank you for your presentation. I absolutely loved it. My name is Lisa. I am a 5-year post-craniotomy benign meningioma brainstem patient. And my question for you is in regards to red light therapy. If you think that's a viable option for post and or symptoms for post and pre-surgery.
So the photodynamic therapy that I showed you in that is technically for, I don't want to use the word malignant cells, but cells that are actively dividing. So as you know, most meningiomas are actually slowly dividing cells. So at most, 3-4% of them, your cells in a meningioma are dividing at a period of time. The atypical ones, somewhere between 4 and 10% of cells are dividing at any particular period of time. And of course, a malignant meningioma has a higher percent. So the more cells that are dividing, more likely are to take up that 5A species under ultrasound. So it depends what you're talking about. If your tumor is continuing to grow, then yes, the photodynamic therapy may be useful. If your symptoms are not related to necessarily tumor regrowth, then no, this would not be effective. But it depends what your symptoms are, because as you know, many of the drugs that treat symptoms, particularly neurological symptoms, don't penetrate the blood-brain barrier. So we have a host of issues when it comes to delivering drugs, whether it's for anxiety, depression, stress, because they're not blood-brain barrier permeable.
Okay. All right. Good to know. Thank you.
All right. Next up is Rona.
Me again. I'm from Philadelphia, and last November I was on what I thought was going to be a lovely vacation to hike with my daughter in northern Chile when I lost consciousness for several days, and luckily was taken to a regional hospital where they correctly diagnosed. I was medevaced back to Philly for surgery. And so grateful. Like I had great care both in Chile and in Philadelphia, and I'm doing well post craniotomy. So as you might have been able to tell, I'm interested in sort of what's happening in research around these things. So you've talked a little bit, but I'm wondering like if you have a particular thing that you're super excited about, and really what are the kind of ideal candidates? I know you said in your presentation, you're trying to get more people signed up for trials? Who makes a great candidate for these things, and what kinds of results are you seeing? And that's a lot, and I understand a short answer is what we're looking for.
Well, look,
The elevated speech.
so let me just remind you a couple things is patients who participate in clinical trials will outperform patients who don't participate in clinical trials, even if the patient gets a placebo. And the reason for that is the placebo effect is real and the Hawthorne effect is real. Hawthorne effect is that observed patients outperform those not being observed. So you have two very basic fundamental principles that suggest that if you have any disease, it could be hepatitis, it could be meningioma, if you participate in a clinical trial, you're more likely than not, based on the data, to outperform anyone who does not perform or participate in a clinical trial. And so the best clinical trial patients are a couple-fold. One, being in a clinical trial is somewhat more labor intensive. There's more testing, there's more treatments, there's more interaction. And that is also the benefit of being in a clinical trial. You're going to talk to a clinical research coordinator, you may talk to a nurse practitioner, you may have an extra navigator, they may pick up a side effect, you may get a blood clot that was picked up sooner because you had a conversation with a nurse practitioner. So that intimacy is very important. It's a big part of our program, is developing the intimacy of meeting my clinical trials coordinator, meeting my nurse practitioners, and we have designated nurse practitioners for clinical research. They won't see a patient who's not involved in a clinical trial. That's a separate nurse practitioner. So you can imagine that this kind of intimacy. So a patient who's an ideal candidate has to be, one, willing, two, participating, and three, their performance status has to be good enough. And so because in general, every side effect, or what we call an AE, every adverse event has to be reported to the FDA. So I can be doing a brain tumor treatment, but if you have diarrhea on post-treatment day 3, I got to report that to the FDA. So obviously, I know this sounds funny, but we used to always say in our residency, sicker patients do worser. And the same goes true with clinical trials. So we have a certain criteria. You can't be below a certain performance status for any clinical trial. And so those really are the biggest thing. The nice thing about it, Rona, is we don't get paid for our clinical trials. We don't make a cent. So we have no financial incentive to enroll our patients in clinical trials, which is by the way, if you're ever in a doctor or nurse's office, you better damn well know if that person's getting paid to offer them the treatment that they're recommending to you, because many of them are. So we have a kind of a strict policy, no conflicts of interest, and making sure that if your insurance doesn't cover it, that the industry sponsor covers it. I get asked all the time, I'm going to Germany for the CGAT vaccine. Do you think it's worth $80,000? And I'm like, no, definitely not. You know how stressful the finances of healthcare are. So we have a lot of exciting things. One of the most exciting things for meningiomas, which I didn't show you, is our intra-arterial Y90 trial. We have a Y90 trial. It's called Yttrium 90. Yttrium 90 is a micro bead that emits radiation. And we actually give it intra-arterially, meaning we use the arteries, not the veins. We slide a microcatheter all the way up into the brain and deploy Yttrium 90. We're actually doing it in liver cancer. That's where the idea from Boston Scientific came from, to go from the liver to the brain. So like Angel said, we're learning a lot from our colleagues and not just relying on neurosurgeons. We're not in silos like we used to be. I think some of that is the advantage of the post-COVID world, whether it's on Microsoft Teams or Instagram or you name it. We're seeing a lot of what our colleagues are doing. And believe it or not, watching my thoracic surgeon who's, a guy named Sloan Guy, and I see what he's doing with a robot in thoracic surgery, gives me ideas that I necessarily wouldn't have had. And it's just because he's posting it on Instagram. So there's a lot more sharing of information and technologies than there ever was, believe it or not.
Yeah, love that.
Thank you.
Cool. Next up is Luciana, who you just recently met.
Hi,
Hi again. How are you? Thanks for my shirt.
I'm doing great, and thank you so much for the appointment. I was very happy. I was able, was a divine appointment because you answered all my questions, and for me it was amazing that you print the MRI and you show me, everything. So I left the office to say I'm in good hands, and and I'm happy to be your patient now.
Well, it's my pleasure.
And as you know, I had almost a year ago surgery for frontal lobe of the meningioma, and after that, I found out I had, tumors. But my questions today, because you answer all my questions during the appointment, I just want one of my Brazilian friends. He has a glioblastoma, and he's doing wonderful. He's on a 3 years that he has been having this disease. But in Brazil right now, there is a research about the Zika virus, and he's on a trial. It's going to have a vaccine in Brazil, and they're saying the Zika virus, the Brazilian Zika virus, can destroy brain tumors. I just would like to know, what do you think about that? This actually was my friend that said, oh, if you have the opportunity, please ask this question. Thank you.
So, well, first of all, thank you. And I'm pleased to say you're doing amazing after surgery, and you look amazing, and I think you're set for a speedy recovery. So congratulations to that.
Thank you.
I have a fun question for you, and then I'll answer your question. What percent of human cancers are caused by viruses? Anybody know? What percent of human cancers?
Oh, wow, that's a good question.
So everyone's like, oh,
I couldn't even guess. I wouldn't even know where to start.
yeah, well, it's
Yes, I was
almost-
saying yes.
it's almost 20%. So almost 20% of human cancers are due to some exposure to a virus. So that's a big number. I'm not, we know that, asbestos may cause mesothelioma, or radiation exposure may cause leukemia or lymphomas, or frankly, pediatric radiation exposure can cause adult meningiomas. But actually viruses, and you've heard of viruses like the human papillomavirus or HPV, and its role
Okay.
causing cervical cancer and now head and neck cancer, the Epstein-Barr virus. When we got mono in high school, that virus now is being implicated in certain cancers, not to make us all nervous because we got mono in high school or college. But so we know that the immune system plays a huge role in illness. Don't even get me started on the gut microbiome and the ability of the gut microbiome to actually alter our blood-brain barrier, but there's a relationship there too. So don't be surprised. The gut neuro axis is actually an intense area of research. And so the Zika virus is trying to stimulate that sort of innate immune response that we see to a lot of external, what we call antigens. And it depends how they will intend to utilize the Zika virus. Of course, they have to make it non-lethal, right? They have to use the part of the virus that makes it immunogenic without killing our nervous cells in our brain. And so that's where the tight walk occurs. So right now, the Zika virus is not part of any successful treatment.
Thank you.
But the way, and Duke ran a trial using the polio virus, and others are using herpes virus, and there are other trials using adenovirus. We've tried almost every virus. The thing that's great about a virus is that it infects the cell. And so you're trying to use that host mechanism to get into the cell and then kill the cell. And so that's the idea of trying to use Zika, because it latches onto cells, and once it gets in cells, it can cause the cell to die. And so I do think there will come a day where we do see successful, what are called oncolytic viral treatments like Zika.
Thank you.
Thank you, Luciana. Next up is Kelsey.
Hi, Dr. John. Thank you so much for your time and your wonderful presentation. My name is Kelsey Knapp. I am living in Frederick, Maryland. I'm about 5 years post-op of a pilocytic astrocytoma, left side cerebellum. And a couple months after my surgery, I started having these weird positional vertigo spells, laying on my left side. Once in a while, if I'm at the gym and I'm doing bench presses on my back, And long story short, I did see an ENT, an otolaryngologist. He did an ENG evaluation, and he proposed that this vertigo issue is still from the brain surgery, and PT was the only option. Now, I've tried PT on and off. It's not working. So why is it not working?
Well, tell me a little bit more about the vertigo. Is it true that the room is spinning?
It's just feels like I don't know if it's a lightheadedness, but like I get this very brief 10-second like feeling of spinning or lightheadedness. So,
Well,
and
they're two different things. I want you to clarify. Spinning and lightheadedness is very different. So lightheaded is, you get up quickly from a seated position and you feel lightheaded. But vertigo is technically objects in your field of view are moving when you are stationary. So you look at the wall and the images are literally moving. So do you have true vertigo? Do you have true lightheadedness? Or are you just disequilibrated, meaning that you feel a little imbalanced?
okay, so then it's a little imbalanced.
Little imbalanced. So yes, that's different than vertigo. And many, many women, and what's always interesting is that women who get meningiomas are also in the same age group as women who get benign positional paroxysmal vertigo or BPPV. So it's not unlikely that that's a different entity. That's vertigo. That's where you turn your head in bed and the whole world starts rapidly spinning. Now you sound more like you have disequilibrium and imbalance, and that likely can be the result of surgery that's near your vestibular nerves in the cerebellum.
Yes.
So your facial
Yes,
nerve.
I remember. Yeah, I remember when I was talking to the neurosurgeon before I met him, he said the brain tumors in the cerebellum pressing up against the vestibular apparatus.
That's why you have vestibular problems.
Okay. Okay. Thank you.
And nothing really to do
Wow.
about that, right? Like the PT is not
Yep.
working.
There's vestibular rehab. There are vestibular specialists that focus. I don't know where you are and who you're seeing from an ENT perspective, but sometimes my
Hopkins.
audiologist, Hopkins. Yeah, I mean, it depends who the neurotologist is, and of course, obviously, I'd like to see your MRI scan to make sure there's nothing, obviously, like a cyst or enlarged ventricle or something other. Um, there may be just what's called cerebellar atrophy from where the meningioma was and the approach that the neurosurgeon took that may be causing you to have just a little bit longer recovery.
Okay. Thanks. Yeah, I know it was like pressing up against the vestibular apparatus, and
Yeah,
I've
yeah.
seen PTs. The ENT was like, I don't think your neurosurgeon did this on purpose. He's trying to remove as much as he can, but it's disrupting your
Yeah,
vestibular system. So,
well, I like to say the cerebellum is the monkey part of our brain. The cerebrum is the human part of our brain. So the monkey part of our brain, you can imagine as a monkey, you're swinging from vine to vine, and that's the cerebellum. So if you have a problem in your cerebellum, you're feeling pretty like seasick.
Mhm.
yeah, and it's just weird. It's only in the evening, laying in bed, or if I'm at the gym at 5 p.m. and I'm trying to do bench presses, and I get a little brief weird sensation, and I have to like hold the dumbbells, and then I'm like, okay, I feel fine. Let me go again. And so,
Interesting.
thank you.
All right. Thank you, Kelsey. Next up is Elizabeth.
Hi, Doctor. Thank you for your allowing us to take up your time. My
A
name's
little bit
Elizabeth.
closer to the microphone, Elizabeth, if you can.
Okay, can you hear? Am I better now?
Yes, yes.
I'm from Fort Myers Beach in Florida. I have 4 mangiomas, and I'm 4 years post-surgery on one that was on the brainstem, but they couldn't remove it. They just debulked it. And they gave me 5 gamma knife treatments 5 months after the surgery. And then 1.5 years later, I had radiation to a tumor in the upper right side. It was touching the optic nerve. It was also abut the carotid artery and in the cavernous sinus. I I lost my hearing in the left ear from the surgery, and I suffer from trigeminal neuralgia. The other tumors I have are on the left optic nerve and the base of the skull, but they're on wait and watch. My question is that lately I have headaches at the surgery site for the one that was the brainstem surgery. And I'm wondering if that is normal based on surgery and my other existing conditions.
If I can fix one thing for you, what would it be?
My headaches.
All right, be more specific. What kind of headaches? Morning headaches, positional headaches, lying down.
Their headaches constant. It's like pressure headaches on the surgery site.
At the surgery site. So is that on the scalp, on where the bone plate is, where your titanium is? Is it frontal? Is it when you lift, when you bend over?
It's constantly on the site where I believe the titanium plate is. And it's constant when I get them. It's like pounding pressure. And even when I lay down or take medication, it doesn't help. I just have to wait through time for them. And I find that it's hard to lay down. I have to wrap something around my neck to support it when I'm laying on a pillow.
So we all have two nerves that run up the back of our head. They're called the occipital nerves. And occipital neuralgia is a very common complaint, particularly of patients who have meningiomas in the back of their head, either in the cerebellum or by the brainstem. And I wouldn't be surprised if you have some mesh or some material that's irritating the occipital nerve. And actually, many times we've blocked the occipital nerve with alcohol or an injection. Sometimes we inject fat. Believe it or not, we can do liposuction and take fat and actually inject it so you're not lying on the mesh or the construct that's bothering you. So it really depends what's in there. And we actually recruited from Hopkins a fellow named Nadi Ben Shalom, who's head of our neuroplastics program. And neuroplastics, I'm not sure if he's spoken to your group, but the
He
neuroplastics
has. Yeah, he did.
is exactly what I brought him here for. So we can do 3D printing of, these kind of things. So I hope that, and I'm happy to look at it, as is Nadi, we would get a CAT scan to look at the bone and whatever's implanted in you to make sure it's not rubbing up against the occipital nerve. And we sometimes remove a lot of the plates. We sometimes, like I said, inject it. Sometimes we just block the nerve with the needle injection. So it really depends. But most patients, we can diminish some of their pain once we understand where it's coming from.
Okay, thank you.
Thank you. All right, next up is Deidre.
Hello, thank you, Dr. Boockvar. I'm Deidre from Denver, Colorado. I'm actually 2 years and change post craniotomy with Dr. D'Amico there at Lenox Hill. And I joined this group 23 sessions ago and it saved my life. So you can see how powerful this is to have you on board and to have this amazing group of survivors here. I had a 4-centimeter meningioma wrapped around my carotid artery, and I still have tumors in my left cavernous sinus that were just too far in the squishy part of my brain that was like, no, we're not going to touch that. I also did 30 rounds of radiation there at Lenox Hill. And right now I'm on watch and wait. And my question is, what do you see with meningiomas that are left, that part has to be left in the brain? I know that I go and have a MRI, etc., but I've had these bizarre symptoms. I'm doing okay for the most part, but I've had these symptoms that I'm not sure. And of course, straight to the ER every time I have a symptom. So are there any things you guys look for, like post-surgery with a meningioma left in the brain? And is there any common symptoms that I might be aware of that might help me just to, I don't want to say diagnose, but like be aware of what I should really go to the hospital for if something happens? Because everything that everyone said so far, this is why I love this group too. I have a lot of similar symptoms. Vision, my left eye was damaged, which I think getting things taken care of quickly helped because it was pressing on my optic nerve in my left eye. But yeah, so it's kind of a general question, but I just I think I struggle mostly with like what should I be aware of? Like what should I look out for, and what doctors should I maybe be seeing besides, you know, Dr. D'Amico?
Well,
Going
first of
forward.
all, you know, my philosophy for my patients is the same philosophy of the NYPD. You know, if you see something, say something. And most importantly, say it to somebody who cares enough to listen. We leave, you know, the beauty of meningiomas right now is that we can leave stuff behind. Our radiosurgery and radiation techniques, much like your iPhone, the navigation system is better than it was 6 months ago. Our navigation systems with radiation are better than they were 6 months ago. So I can radiate smaller volumes with more precision than at any time in history. And that's just getting better and better. And so as a surgeon, that helps me a lot because I can start saying, okay, it doesn't matter if I leave 25% of this tumor stuck to the optic nerve or to the cavernous sinus or to the brainstem, because radiosurgery 9 out of 10 times will stop the rest of it from growing. So we must always, you know, I always say if it sticks, it stays in my patients, meaning I never have a tug of war with a person's meningioma in surgery. If it sticks, it stays. And I don't pull on it. So, and if it sticks, it's going to get radiated potentially, or we're going to conservatively watch it and radiate it when it grows. Just to let you know, there are two types of kinetics when it comes to growth. There's linear kinetics, which is smaller things start small and they grow linearly over time. But actually, meningiomas can have Gompertzian kinetics. Gompertz was a German mathematician that the first part of the curve is linear when it's small, but at some point they plateau and they stop growing. So we never really know where meningioma is. Is it on the linear part of the curve or the Gompertzian part of the curve? And so obviously all the things that you've heard today, whether it's headache, pain, new weakness, lethargy, obtundation, double vision, nausea, vomiting, if you see something, say something. And it's making sure that you're, you know, I always say one of the best things about our program, obviously we have great doctors and great surgeons, but we have great nurses and great PAs and great navigators. So there are also, I always like to say there are 3 A's to a good doctor: availability, affability, and ability. And it's often in that order, believe it or not: availability, affability, and ability. And so people are like, oh, I want the doctor who's going to be, you know, this. Surgery is the easy part. You know, it's navigating the, you know, being available for the patients when they have complaints. And as you know firsthand, surgeries are high risk. And some of these complaints, whether it's vestibular dysfunction, pain in the head, double vision, we have to be there for our patients. And that's what we tell our nurse navigators, our PAs. One of the other things I always like to say is the post-COVID world, we're so integrated now with Microsoft Teams that my chats about patients is literally 24/7, which you may say, well, John, does that, you know, bother you? You're going on spring break tomorrow with your daughter. And the truth is, it really doesn't bother me. It actually saves me time to be in constant communication because the communication lines are seamless now. And that's an advantage to you if you're having trouble.
Thank you.
All right, thank you, Deidre. Next up is Lori.
Hi, Dr. John. I live in Fairbanks, Alaska, and I'm 10 months out from a meningioma on my left frontal lobe, but they also found at the time of surgery, they found another meningioma on my right side, exactly, almost in the exact same spot as the other one. But my question is, through a CT scan, because I can't have MRIs, do meningiomas ever disappear on CT scans?
will they don't just disappear because of some magic. Um, unfortunately. That being said, as you know, meningiomas have estrogen and progesterone receptors on the surface of them, and they can actually ebb and flow over time, but they're not going to disappear.
Okay. Well,
Um,
it didn't disappear on my scan. It turns out the radiologist didn't see it.
well, that
at
was what I was going to say, especially on a CAT scan. You know,
Yeah.
CAT scans, unfortunately, are 1980s, imaging modality, but we still see a large, fortunately for a meningioma, you can see a lot of them very well with just CAT scan alone. But you should be alerting your, and there's another thing, you should be alerting the technician who's doing your CAT scan. They can put a marker over every meningioma and stick a little marker on your scalp and almost give your radiologist a little hint to know where they're looking. And there's two reasons for that. Is the technician may do a certain type of cut that includes that area. I've seen many patients where they're like, oh, a CAT scan, MRI of the brain, and they stop here, but the meningioma is on the apex. So the last slice misses the meningioma. So if you walk into your MRI, particularly if it's a new place, you tell your technician where your meningioma is. Because they'll say, oh, you're John Boockvar, date of birth, 6/11, and then you're here for meningioma. And I say, you know what? I'm here for my right frontal meningioma that's approximately right here.
Okay. Thank
Good
you.
to know. Never had heard that before. So
Good to
definitely
know.
good to know. All right, next up, Brenda.
Angel,
Hi.
I only have an hour. I'm sorry. I thought
Oh,
we were
that's
doing an
okay.
hour. I'm so sorry, but I don't want to cut it short. But I just wanted to give you the heads up because I'm full. I have to stop in a little bit. But anyway, go ahead.
Yeah. Brenda, you want to ask really quick?
Yeah, I'm Brenda. I'm from Tucson, Arizona. I don't have a meningioma. I actually have a oligodendroglioma, grade 2, which was removed back in 2020. My question is, are you doing any research with diet, like metabolic ketogenic diet, in conjunction with the standard tumor therapy? I've just been reading a lot about that.
So obviously, very good question about diet. And I have not been doing a lot of research with the ketogenic diet, but all of my patients come in, and I do have an onco-nutritionist on our staff that I refer our patients to. But what I will tell you, and I'm going to give you a little peek of my board here. On that board are 9 or so alternative drugs that we use for patients like you and many of my patients. And I can tell you I'm on many of them as even a person without a brain tumor because I believe in the anti-cancer agent. One of them is metformin, which, as you know, is a diabetes drug that inhibits the release of glucose from your liver. And that, in some studies, shows a 40% risk reduction of cancer. So just to let you know, our entire office is on 500 milligrams of metformin. So there are benefits to things that include those that obviously it's a similar thing to the keto diet. You're trying to reduce the amount of glucose that a cell has to metabolize. And so metformin is just an easier way. You don't have to go on a different diet. I can eat anything I want and just take a pill of metformin every night. But there are some real benefits, and I would definitely encourage you to meet with an onco-nutritionist in your area just to make sure, you're not destabilizing your gut microbiome and do other things that can be potentially harmful, all because there may be somebody on TikTok that says they're getting better on a particular diet. So I just want to make sure it's scientifically grounded. We have some very, very good studies. I can tell you, a Mediterranean diet is probably just as healthy as a ketogenic diet. And so, again, I'm not a diet expert. We're not particularly studying in clinical trials the ketogenic diet, but I can tell you not alone. A lot of our patients come to us seeking guidance on that.
Yeah.
Thank you.
Perfect. Well, thank you. That actually got around to everybody who had a question today. So we did it. We fit it in. Thank you, Dr. Boockvar. We always really appreciate your time and attention. We're super enthusiastic about fundraising for you and your research this year, and we can't wait to come to New York and meet you and your team. So we will be in touch with you. We appreciate your time, and that's a wrap.
Wow, we got it done.
We did it. We did it. Slides and all,
Well,
everything shook out.
Yeah, so best of
Lovely.
luck to you all, and I look forward to meeting you all in person, and have a great weekend.
Thank you.
Awesome.
You too.
Thank you so
Thank you.
much.
Thank you very much.